Our next session is getting some updates from the National Committee on Vital and Health Statistics, or NCVHS, the Subcommittee on Standards. We have Tammy Banks, who is one of the NCVHS co-chairs for the Subcommittee on Standards. She's a principal and consultant with ImpactQue LLC. And then we also have Rich Landen, who's virtual, also an NCVHS co-chair on the Subcommittee on Standards. Before we get started with our session, Charles would like to make just a few comments.
Yes, so thank you, Pam, and Rich and Tammy. Forgive me for taking a couple of minutes of your time, but I have a couple of announcements. One is, yesterday was Michael McNutt's birthday, and he's swore that he was not happy when I said I'll announce it. So I may have lost my camaraderie with Michael. But anyhow, so happy birthday, Michael. And then secondly, at the beginning of December, and Rich was on, and I assume he's still live, is Rich his term at NCVHS is concluding, and Rich has been an unbelievable supporter of the industry, of WEDI. When you think back on all the things that he's done, I just can't thank you enough, Rich. And on behalf of WEDI, and when I think back on all the work you did in the hospital system, and certainly with X12, and with many other groups, NUCC, NUBC, the list goes on. But we sincerely appreciate all that you've done, and I just wanted to give you a little thank you before your term at NCVHS ends. But we certainly still have your address, and I want to thank you again. So I'll turn it back to you.
Well, Charles, I really appreciate that, because now I can scroll through like 3 pages of all of Rich's accomplishments over the past 8 years. And I know many of you volunteer within these organizations, and it's really a passion of love, but it is very time-consuming. And Rich, again, I want to thank you as well. But you can always go to the NCVH website and see a lot of his work product, from the ICAD to the predictability roadmap to the convergence. I mean, we can go on and on, but just know everything is appreciated. All right, let's move on. For those of you who don't know, NCVHS is a federal advisory committee to the Department of Health and Human Services. And the Health and Human Services encompasses a lot of different branches within the government, from ONC to CMS to the National Standard Groups to the Office of Burden Reduction, many of them whom we had speak today. So we work in partnership with these federal agencies and advisory bodies to ensure that the committee's work is synergistic and in alignment with administrative priorities. And Rich and I are from the Subcommittee of Standards, which we really focus in on monitoring and making recommendations to the full committee, or actually create the work product for the full committee to make recommendations to the secretary on health data standards. That includes the professional claims standard, ICD-10 code set, and includes implementation of the administrative simplification provisions of HIPAA, Medicare Modernization and Improvement Act, and the Affordable Care Act in associated areas of interoperability. And if you go to the first slide, do I have ability to do that? Awesome. The committee recommendations have been used to inform HHS policy. You guys were talking about them yesterday, and we'll go in a little bit more detail today. Rulemaking and programs over decades. NCVHS is statutory charged with responsibility, again, for providing advice on implementing the HIPAA administrative simplification provisions, also named in the Patient Protection and Affordability Act, to provide input on rulemaking for additional standards and operating rules. and has advised department secretaries on a range of matters regarding HIPAA privacy and security rules. And you also heard from Jamie yesterday in regards to ICD-10 work that's being undertaken within the work groups. So always when we have these conversations, one question that always comes up is, what about the roadmap? There's so much going on within the landscape. Where do we focus our energies? And these are just some of the list of ongoing activities, and it's definitely not inclusive, but it all relates to the HIPAA standards and code sets. We have the NCPDP proposed rule. We sent the recommendation for F6 back in 2020, and we know that that's being worked on. Recommendation, adoption of the healthcare attachments. We know that proposed rule is in flight. We sent those recommendations in 2016. And also there's a lot of other regulations that's going to intersect with HIPAA, especially with the dialogue of prior auth, right? Where we see that in the prior auth reg, but we also see it in the Mental Health Parity and Addiction Equity Act reg, and also other initiatives as well. So today what I'm going to do is, go through our priorities very quickly through the standards and operating rules, but what we really want to do is hear from you. One thing I hope you realize is all the work that's done creating letters to respond to RFIs, the coming to the NCVHS and providing testimonies. We hear you. We read every word. We try and listen, and I hope the recommendations that come out really reflect where the industry's at, because we want to hear from you. And I know Donna was like, Tammy's not going to respond, but the brainstorming that you were doing is what we want to hear, right? And in addition to what's wrong or what should be changed, collectively as an industry, what needs to be done to move the industry forward? We look for you to hear what makes sense. And WEDI is such an interesting organization where multi-stakeholders can come together and have those dialogues, right? And then coming to us and sharing where the industry perspective is really what we're looking for. And so we deeply appreciate each and every one of you who are part of sending those letters, compiling those letters, being subject matter experts, because without you guys, obviously we would not be able to make recommendations through the full committee to benefit and really reflect where we need to be. So we're going to go through those. If we have time, I'd like to go through where we are with the health data standards in the movement of Convergent 2.0, or what we're calling it Modernization 101. And then, again, just a reminder, if anybody did not listen to the ICD-11, please take a look at it on the streaming. It's a lot of good work that's going on in that regard. So, transaction standards and operating rules. First question is always, okay, what's the difference between standards and operating rules? So we have it up on our screen here, where the standards are the implementation guides, right, the instructions, while the operating rules are more the business rules and the guidelines to really enhance the value of the standards in the implementation guide. As someone mentioned yesterday, and I think Bob from CAQH mentioned as well, they brought a proposal forward with the listed operating rules, eligibility and benefit data content rule, claim status, payment remittance, eligibility and benefit, all those were updated infrastructure rules, connectivity rules, as well as the single patient attribution data content rule. So the full committee moved forward those to the secretary and recommended those move forward for rulemaking. While the attachment prior auth, a lot of the testimony, while was very supportive of the concept of the operating rules, was really concerned about until a attachment final rule is created, wanted to make sure that these operating rules fell in line with where that final rule is. So what's next? Well, the secretary then has the option to consider if they want to move forward with the rulemaking or not. And then if they agree to move forward, under the ACA, they have an expedited rulemaking requirement for those operating rules. So then we would see an interim final rule, and then we would also see a public comment of 60 days. So X12 submitted two requests to NCVHS. The first one is in regards to claims and payment remittance advice, to move from 50/10 to 80/20 for those sets of standards. All the other transactions would remain at 50/10. And you'll see a list of all the criteria that NCVHS looks at in order to determine if a recommendation to adopt should be forwarded to the Secretary for consideration. And you'll see in the bold the addition of and cross transaction, because after the testimony and after reviewing the comment letters, we realized that we really needed to pull out that point of cross transaction impact. So just in a nutshell, is there value? Is there availability of information to confirm what the impact would be from the previous transaction, as well as the impact across the existing transactions? And is the proposal really address where HIPAA and ACA really wanted us to go in regards to interoperability? So our recommendation was not to adopt version 80/20 for the transactions I mentioned, but the key thing here is at this time. And that's something that gets dropped, in the conversation, at this time. Why are those three words so important? When we listened again to the testimony and the letters, I have to keep going back to those. Adopting a subset of 80/20 transactions versus the 80/20 suite, it's a new way of looking at it, right? And so we really have to be thoughtful with this first set of transactions on what we need to make sure that it's ready for national implementation. What does national implementation mean? It needs to be able to be implemented by the community hospitals, by Medicaid, the smaller payers, the large payers, the small physician practices, everyone out in the national industry, not just the large innovative organizations. And so that really brought us to the recommendation that we really need to understand a little bit better, right? What is the evidence of the backward compatibility and the cross compatibility to the existing 50/10 transactions as we move down this way of chunking or the subset introduction of these standards? The other is, what is the cost savings, the benefit, the value, right? When we talk to payers or we talk to providers, they're looking for increased automation. They're looking for reduction in call volume. They're looking at, the not having to request additional information. Those types of metrics that are high level, again, not the final rule type of information that's needed, more the high level. How is it actually going to have an impact on the business, and why am I going to invest the resources to make it happen? Because to be honest with you, if everybody doesn't invest in it and use it, we're talking provider, payer, vendor, we're not getting the value. It's just an expenditure. And we can't afford that now in healthcare, right? And the other is raising awareness that, remember 50/10, what was the biggest driver for 50/10? ICD-10, right? Well, if we move forward with whatever version the Secretary moves forward, we all have to be cognizant that the ICD-11 is going to require a new standard. And there's also some other talks in regards to the National Drug Code is looking for changes as well. So those have to be front and center, is when the investment's made, another investment's going to have to be made, which may be appropriate, which may be not, but it needs to be front of mind in order to be thoughtful. And this is just a slide just to kind of echo what I was trying to say. If all these proposed rules move forward, what we would be sitting with is the claim in the ERA at 80/20 version. We would be sitting with the prior auth at 60/20 and the related transactions. And we would be sitting at the claim status, benefit enrollment, and payroll at 80/30 version. And again, the question is, what would be the impact across all these different versions if they were in play and when they're introduction? That's the question that we're really looking to answer. So, just went backward. So again, NCVHS at this time, right? We acknowledge we need to move forward. I don't think anybody's against moving forward, but we need to be thoughtful and make sure when we move forward, it makes sense, it brings value, and we know that there won't be additional unknown cost in the implementation or any reason not to implement to get the true business value that these standards are intended to give us, right? So what's next for this proposal? The Secretary is going to consider the recommendation, and they'll make a determination if they want to move forward or with rulemaking or does not. X12 also brought forward version 8030, again, of the claim status, the payroll, and the premium payment. We have been getting some conflicting information from what was testified and in the letters, so we're just holding off on this transaction until we can take a look at our roadmap and figure out where it makes best sense to move forward and begin to take a look at that version. But again, I just got to echo, and this is the only thing I really want you to take away. Your input is critical, right? These are tough questions. These are the conversation that you need to have in these forums, right? What makes sense to make sure that these add value and they really do drive a reduction in cost, bring benefit, and ultimately help the patient, right? Rich, before I go on, is there anything that you would like to add in regards to my quick review of these recommendations?
No, nothing I'd like to add. You did an excellent job of pulling out the pithy materials and avoiding a lot of the niggling detail in what is an extremely complex set of checks and balances that HIPAA created almost 30 years ago now. So I'm sure we'll get into some more interesting discussions as we get into questions from the audience.
Yeah. Anybody have any questions at this point? I have some more to go through, but again, and I'll be honest with you, Rich is really good at, Tammy, remember, you got to ask the questions. And, things that we are very interested in is, what is your plan and anticipated standard development projects? What should we be thinking about? What are the metrics, the key things that you're looking at to drive your business forward? What are your work plans to, improve star ratings, reduce overhead? Because that all relates to, as we're visioning out in our work plan, to make sure that your key areas are included within that topic. And that's the topic I'm going to move into next. What impact do you think AI is going to have on your business or on the implementation of new and updated standards? What physician-provider initiatives are you investing in the future? How do you envision APIs and HIPAA current standards, for example, X12, NCPDP, and working together to meet your objectives, right? These are the questions we have to ask now to begin making sure that they're on the roadmap and the work plan moving forward.
Tammy,
yes.
Mary Lee has a question.
Mary Lee.
Hi, and Donna's after me, I
Okay.
think. I'd like to talk for or ask you to speak for just a moment on the intersection between the X12 standard and ICD-11. I feel like we're kind of at a little bit of a chicken and egg moment where we don't even know what ICD-11 is going to really look like, depending on whether a clinical modification for the United States is chosen, or what of ICD-11 are we going to actually choose to use in the United States if we choose to use it. But yet I feel like we've charged X12 with making sure that the guides can support this, even though we don't know what it's going to look like. Are we going to hold those guides from moving forward for this gray thing? It just feels like
Very
a
good
chicken
point.
and egg.
Yeah, there's two ways to look at this. One is the first two recommendations are key, right? And because of those recommendations, the third recommendation has to be made. Because whatever happens moving forward, if new implementation guides come forward, this has to be thought about, right? The second is ICD-11 is already done. It's created. And I'm just going to say go back to ICD-11 and read the view, and they'll talk about how they're having different care coordination codes, and they're having, and I don't have the slide up, so I can't use the appropriate words here. And I know, Rich, you know this better with me, but they have the cluster length codes. And so if, yeah, and so the point is, if X12 has to be aware of it, right? And now you're aware of it. And then you have to figure out, can it be put in? And what is the information you need? And then, if you don't have enough information, that needs to be brought to that World Health Organization or brought back to the work group so you can get that information and we can figure out what that timeline is. But it's a coordination, right? On when and how can that get put in. I know that Andrew was saying releases are going to be every year. When does it need to be completed to be in the next version? We have to have that conversation. If we don't have the conversation, we'll never get it in, right?
So you know what I'm going to say.
Oh, please do.
Hi, Rich. You can't see it. One of the things I'm concerned with, I'm going to bring up 2 or 3 things, but I'm going to try to do it in rapid fire. One of the things I'm concerned with is we're setting precedent for the other transactions that really do have heavy volume in the industry, and the billions of transactions for the 270, 271 that are exchanged every year, the billions of claims that are exchanged, that are sent every year, the 835s that have significant value. I'm afraid that if we're doing this for the 835 and 837, that no one's going to give a rat's you know what for the rest of the transactions, and we're setting an improper message. We're setting and sending. That's the first thing. Second thing I think I'm also afraid of is we're, like Mary Lee said, we have this ICD-11 component, this backward compatibility thing. Not a lot of things are backward compatible. 5010 wasn't backward compatible with 4010, and that wasn't a requirement then. I don't know why it would be a requirement now, because the whole point is to move forward. Nobody should be moving backwards. So if we're going to put that as a criteria, then nobody can do it. I mean, technically nobody can. When you take stuff out, you can't just magically put it back to be backward compatible. The third thing I'm a little worried about is, especially with the 837 and the 835, but again, going back to the concept of precedent, if we're going to wait for ICD-11 to be accommodated in all the books, that might be fine for our harmonization task group that's putting things together to socialize it across the books. But like Mary Lee said, we don't know what it looks like necessarily yet, how it's going to behave in the books yet. The 270, 271, we don't do anything with procedure codes and diagnosis codes right now. So we shouldn't wait for something that isn't really supported today. The 837, I get it, because it's more important for the 837, but the 837 has other advantages if we move forward, that now we're going to try to bundle the 837 accommodations and implementation with the ICD-11, and I know what ICD 9 to 10 look like, and that was a crapshoot. That was horrible. And now to do that coupled with going up to an 837 80/20 is going to be horrific. So I feel like what we're doing is we're making it worse, not better. And then the fourth thing I'm going to say, and final, rapid fire, like I said.
Hey, Donna, I can't keep track of all
Somebody
these.
should be recording this, right? Yeah, he's recording it.
I think I got 3 of them.
He's
so you'll have to
recording it,
come
he
back
can
to me.
transcribe
okay, go
it.
ahead. No, they're all good.
The fourth thing that I was going to say is that, and now you made me forget.
Well, Donna, I'm going to start, and you tell me where I'm, okay? The first thing is you're like, why are we setting a precedence, right? These recommendations that we brought forward have been a conversation at NCVHS, I'll say for 20 years, because I know I was on the other table and I presented these. So I don't think any of these first 2 recommendations should be a surprise. This is where we were moving, right? And there's a difference between what you say is a requirement and a difference between explaining how something is or is not something. We didn't get any analysis, nothing, right? And I think the expectation, and this is Tammy speaking, so Rich is here to keep me out of trouble. the expectation is the vendors are just going to figure it out instead of, okay, we did, and probably the analysis is done, right? Then just bring forward, this is what it is, right? And you're right, sometimes data elements will be gone. Well, how many? Are they key to business cases? We don't know, right? So it's more an explanation. Show the work that was done, right? Instead of, this is a utility, accept it, right? And then the other is, I think it's really the technical and business conversation, right? When I get a list of technical changes, I can't extrapolate them to the business use case. So is, X change going to automate this so now I don't have to have phone calls? And if so, on a typical practice, is it going to reduce 20% of my phone calls on that topic?
Well, and that's kind of where I was going, is it's going back to what Mary Lee said again, and I swear we're not doing this on purpose, but this whole ROI concept where it's a chicken and an egg. I can't prove how valuable moving to the new transaction is if I don't have support from everybody to move to the new transaction. I want to move to the new transaction so I can show you how valuable it is, and if we keep using this as an excuse to not move forward, we might as well just, and this was the fourth point, we might as well just say we're not doing standards anymore, because that's what we've had to do now for the last 15 years, is create things to fill the gaps because we haven't moved forward. So now we're basically doing what we did pre-4010, which is have a whole bunch of ways to skin the same cat. Sorry, cat lovers. And now what we're going to end up doing is we're shooting ourselves in the foot. So we need baby steps somewhere.
No, I just got to ask you one question. When you're at X12 and you're considering a data, and I've been there, and I know you guys are very thoughtful about what goes into a standard. And I remember presenting at X12, and I had ROI numbers, why these fields were important. That's the stuff that needs to be exposed, right? It's already there, but just explain why and why it's an impact, because we can't have 50-10 where people implement a standard and they don't implement for the business case, because that's the value of the standard, right? So the information is there, in my opinion, but again, you guys know more than I do in that regard. Rich, would you want to add anything?
An hour's worth, but
I know,
won't.
I'm trying to be short.
It's a very complex situation. I think Tammy was absolutely right, is what we're looking for is a little bit of rationale. We're not looking, the accountant type spreadsheets for the dollars and the cents. We're looking at the overall value. And that's really hard to do because of the concept of a standard. And Donna, you brought this out, standard is in theory, it's one size fits all. But if you look at the US healthcare industry, it's not a homogenous it's not a homogenous industry. It's made up of a lot of different subsegments, like what's an acute care hospital, a tertiary, primary, secondary medical centers, small practices, dentists, pharmacists. You've got fee for service. You've got bundled payments of different sorts. You've got Medicare Advantage. There's all sorts of nuances so that any one given change will benefit one or more subsegments in the industry, but not the entire industry. That results in a situation where NCVHS gets comments in from the different subsegments saying, oh, this is the greatest thing since sliced bread, and this does nothing for me. So we need a way collectively, and by we, I mean the standards development organizations, the DISMOs, CMS, and NCVHS to kind of take HIPAA and set some rules for what is it that demonstrates sufficiently that it's a good value. I mean, Tammy's done a great job at presenting some of the questions. And there's a fundamental in IT that I learned many, many years ago in my hospital days, is you don't bet the farm on an unproven upgrade to your system. And so, Donna, this goes to a lot of your questions. Okay, we've got the slide that Tammy used, we have some on 50-10, we've got some on 80-20, we got some on 60-20. Well, there's nothing theoretically wrong with that. But pragmatically, where's the evidence that the different transactions on the different versions are going to play nicely in the production world? And that's kind of what we're looking for. And that kind of segues into ICD-11. ICD-11, there's two components, there's two possibilities. One is we will not go with a US specific clinical modification. The second possibility is we will. So we were looking for some things from X12, basically address that. One is assuming, under the first assumption, that we go strictly with the World Health Organization's, with the cluster codes and the extensions and the pre and post coding. How will that work with X12? Pretty straightforward. The second scenario, less straightforward. If we go through a clinical modification, what then? But that's also important from an NCVHS perspective to hear from X12 as to what are the challenges. So as we get into a national discussion, not an SDO discussion, but a national discussion about a potential US clinical modification, what are the things from X12's perspective, and by extension, all the other SDOs that may be involved, what are the things that we need to pay attention to? And that, I think, that's those two conversations, the no US clinical modification, yes, US clinical modification, that's what we need to hear early on, because you look back at how long it took the country to go to ICD-10, it just is a question that needs to be resolved sooner rather than later. So again, a lot of complexities here. What works for one entity doesn't necessarily work for another thing. How do we balance all this? And undermining all of this is the testimony, the letters, the conversations NCVH has had with all of you going back decades, is we really want to get to a point where there is some predictability, and predictability meaning budget planning, resource planning, project planning ability. And we just don't have that. We never did with HIPAA. And that's really one of the big nuts we're trying to resolve through all these conversations about the various components that we're facing.
Yeah,
End of soapbox.
That's okay. This is important.
Let Joe ask a question, and then Tammy can go back to her presentation.
I'm sorry, I probably won't deliver this with as much passion, much needed passion as Donna, but
We hear the passion.
I will try to be as passionate as possible. I think, it is complicated, and part of it is HIPAA itself. When HIPAA came out with these guidelines and rules in various organizations, we have to live within those confines. And unfortunately, we didn't have AI back then to figure out what we really needed and what the data says. So one part that I feel has to be part of the education or information flow up to the decision makers is how much is being lost or how much more it will cost by not doing anything. And so if it was promoted through a standard organization, either the standard organization, we have to look at how do things get promoted and why do they get promoted, and is that appropriate? Because we have to do it at the point of ingestion, because what we're really talking about is the convergence of policy with technology. And the policy is, what is the standard that we're going to set? And I agree with Rich that this may help one segment but not the others. Unless we're going to have different standards for different segments, that's all part of the equation. And by not doing anything, more and more things are stacking up that are going to become critical, that are even cost more money. So inaction actually has a cost as well.
Exactly, and just laying out what are those, right? Hey, I want to go back to Donna. You were going on and on and on. Did I get them all? Or Rich, did Rich capture everything I missed? Okay, good. Oh, no, honestly, you guys, it's important, and I'll go on with this because I know I don't have much time, but I mean, the point is, and I'd love to hear from you in the room, what do you need? What do you need to go back to your organization? Obviously saying, well, there's a regulation helps you get dollars, right? But what do you need in order to truly do the business case? Because I know we heard from the providers that they're not getting, I'm sorry, I don't like mics. And I got a low voice. What do you need in order to enact these business cases so the providers see the ROI and you get the ROI? And we hear that all the time with 50-10, right? Where these are great business cases, but the physicians aren't using it. Well, why? There's a reason, right? So, if we can lay that out at the beginning of this conversation and have that fuel when you go in for the investment dollars, then you can enact the business case and you have that what you need, right, in order to truly get the value that these standards have attempted to bring. But anyway, so let's go on. You guys have all heard about Convergence 1.0, Convergence 2.0. Well, we're really creative over here at the Subcommittee of Standards, and we're going to be bringing this to the full committee. So we're working on Modernization 1.0. And what it is basically moving forward, taking a look at the value of the predictability roadmap, the convergence, and thinking about what has changed in HIPAA since the past 20 years, bringing up the point that was brought up that HIPAA is kind of a constrictive regulation. And so some of the changes that we uncovered, and I'd like to hear if you think we're missing something, is in regards to the administrative and clinical data flows, right? They're commingled. The data is being used for both administrative and clinical use cases as well as others, right? Risk adjustment, STAR, increasing the STAR ratings. We also have that these electronic exchanges are exceeding the uses envisioned by the HIPAA framework, right? Again, aligning the components of clinical data with the administrative processes. We got demographics, laboratory results, social determinants of health. All of that information is critical in all the different settings. We have mobile apps now and a lot of different care delivery venues that we never had thought about when the creation of HIPAA. We have the standalone data systems are becoming connected now, right? We have new actors, especially when we look at the apps and we look at moving in the public health and cost and quality assessment and research, right? There's more use cases that are being put into play versus the traditional ones that were envisioned under HIPAA. We also have commercially available data now, right? PHI, non-covered disclosures under HIPAA. There's more, again, the big one that keeps coming up, right, is where the data now includes purchase history at the drugstore, right? So privacy and security and the expansion of that scope is just, again, something we never, ever anticipated. Consumer-focused price transparency regulations, again, a new way of exchanging information and including the patient in that conversation. It's not just the health plan to the provider anymore. And they focus on social determinants of health, community health. The other thing is, again, we're migrating away from the mainframe, right? And batch processing. We need more real-time exchange of this information at the point of care, which, again, was not realized under HIPAA. and a lot of new technology. We also have generative AI. AI's ability to translate among all these different standards and between standards to gain harmonization. Never had that ability. Where is that going to take us in regards to these standards as we look at API and we look at X12 and we look at HL7? Again, we need to move to another version to get ICD-11, whenever that will be. That's going to require a whole new code set. So any piloting of ICD-11, these standards would not support that at this point. So the piloting will have to be done outside the standard. And also the change to value-based care. And we can talk a whole session on the evolving value-based care and how is that going to impact the administrative transactions versus the use of APIs. And also, again, I just have to reiterate the data flow. It's a whole different model. It's not the payer-provider anymore, right? It's patients, providers, health plans, public health. And the expectation is that it's going to be bidirectional and multi-directional. Again, this was not anticipated under HIPAA. And so the vision that we have discussed with the full committee and will be bringing to our conversation later this month is, we're really looking to figure out how do we standardize data capture and improve the availability of data across the healthcare data ecosystem that supports individual healthcare and wellness, health policy, privacy and security, and healthcare quality and safety. And in the small print, you'll see all the different aspects underneath that vision statement. But bottom line, I think it's we're really trying to figure out how do we get the ultimately delivery system of information that's going to benefit all our stakeholders, especially the patients, right? So what we are looking at, and again, these are just conversations. I hope you guys will all join us on the full committee meeting later this month. But we're looking at really reviewing the relevance of HIPAA in the current healthcare ecosystem. Does it make sense? Does it make sense to name standards in a regulation? What's the impact of the APIs and the other standards that are named under HIPAA? That's a conversation that needs to be had. Examine mature and emerging standards. I think in other sessions you were talking about the prior auth API, and you were talking about the X12 278. Can they be in harmony? Can they not be in harmony? Is there different business use cases for each of those standards? Those are conversations that have to be had, right? It's one workflow. How do we make the appropriate information exchange vehicles to support the different business use cases depending on who's sending and who's receiving? Because the sender and receiver is not the health plan and their entity and the provider and their entity, their business partners anymore. It's more expansive. And the harmonization of standards and data requests. That's another big topic, especially again, as we expand the different stakeholders and the partners in this exchange, whether they're covered entities or not. It's something that has to be discussed. So our next steps is, again, to continue this discussion, obviously meet with Donna and hear additional comments on how to move forward, but really looking, for the partnership with WEDI as well. What makes sense to you and your organization? This is the time to be vocal. Say, what do you need? Everybody goes, if something happens, they go back, they create it themselves, they go to the finance gentleman or the CIO to get dollars. What do you need? Help us help you. Reach out to the WEDI organization, the WEDI work groups. Share what you need. Be part of the conversation. We're going to be developing the work plan, engaging with OBRI and ONC and NSG. Full committee discussion is again later this month. And again, we're going to continue to ask you for your feedback because you guys are driving the ship. You just got to tell us what makes sense, right? And how do we do it collaboratively? Because again, if all the stakeholders don't get value How are we going to implement this in order to make sure the business use cases are realized? So this is the plug. Everybody, put on your calendar, November 29, 30. That's when our full committee meeting is. We'll be discussing our scoping document. We'll be discussing those 3 draft projects to see if they meet in the prioritization of the work plan for NCVHS, along with the privacy and security work topics as well. There's going to be an ICD-11 report out. Their Privacy and Security Committee is working on a letter in regard to the HHS Secretary rule that was recently proposed. We'll be working on our report to Congress, which is a statutory requirement that we report out every 2 years. And also we'll have a panel discussion on approaches used by SDOs to evaluate and assess the readiness of new and updated standards prior to release for national implementation. So we're hoping it'll be very informative. There's always a public comment period, but please, we need your input. Because we're really at a pivotal time, and whether we agree or disagree, it doesn't matter. All those opinions are important, so we move forward in a thoughtful manner that makes sense for the healthcare industry at this critical point in time. Rich, would you add anything? I love putting him on the spot.
I think you've done an excellent job as the questions were excellent. It's a very complex, it's never a stagnant situation. There's so many moving parts. So much of it is regulated by federal law, federal regulations, and federal procedural acts, the Administrative Procedure Act. So there's a lot of challenges, but what Tammy has outlined, I think, is a very ambitious effort to look at everything that's going on, all the opportunities that are out there with new technology, new possibilities, new delivery models, new payment models, and figure out what changes can we make in the near term and the middle term that will advantage the industry and the country as a whole. NCVHS is a vision organization. We've got a good representation of knowledgeable people from different aspects of multiple industries, different backgrounds, different perspectives. And to put that all together is a challenge. And as Tammy has said repeatedly, we need your input. Where's the biggest bang for the buck? What are the biggest obstacles? What are the opportunities? One thing that I didn't hear in the discussion or the questions today is you look back at the standards, you look at HIPAA, look at all the opportunity that HIPAA standards adoption has created for innovation, new ways of doing things, new or ways of doing old things better, quality management. It's just opened up a whole variety of possibilities, no matter what your organization is. How can you better serve your constituency? And I think that's another aspect of standards developments that needs to somehow be factored in, is what new opportunities does an updated standard allow or create for the industry. So Tammy, job well done. You've covered a complex and 30 years of HIPAA, ACA, and related both legislation and regulations in a very thorough manner, stressing the dynamic tensions that exist between the different components of the system, and again, a plea for coming together for conversation on how we all advance for the common good. So well done, Tammy.
See why I bring Rich? No, I'm joking. But Donna did have another question. She just didn't remember. Okay, she has 2 additional questions, but the one I remember from yesterday, Rich, and I was going to ask you, because you have the history of this better than I, and I know I had to be corrected because I misclarified what NCVHS meant by, now I'm blanking on the language, Rich, in regards to a smaller, bite-sized pieces. can you elaborate
bites.
just, yes.
Yeah, what NCVHS has heard consistently from industry testimony, participation in workshops, public comment periods, formal responses to the various things we've done. And again, my personal history with NCVHS as a member goes back 8 years, but my engagement with NCVHS and the work products of NCVH go back a lot farther. We've heard a consistent message that, hey, we need to be able, we as the implementer, so the payer side, the provider side, the vendor side, we need to be able to anticipate these changes. We need to be able to budget for them. We need to be able to do the timing of the project development and implementation. So we need a much more predictable way of approaching the implementation of standards. So in the NCVHS predictability roadmap and the related projects, we've come to that conclusion. We've put that out as a aspirational principle, and so we're looking at different ways of how do we do that. We were thinking primarily, I believe, along the lines that we might want to consider moving to a more industry controlled cadence every 2 years. We looked into that in conjunction with, as Tammy mentioned several times before, working together with CMS, and there were just a lot of HIPAA constraints in that, and approaching and advocating new legislation wasn't something that was in the cards politically, economically, or scope-wise for NCVHS. So we were thinking in terms of what else can we do? X12 came up with the idea of this, what we have now called chunking, where we move several of the transactions ahead as one version packet, and then a year later we move additional versions forward. And in theory, again, there's nothing wrong with that approach. In practice, what we found the first time this came through was there wasn't the evidence that would demonstrate that there is acceptable risk level of those new transactions, the new versions, not working together on a day, but talking about a production scenario. There was nothing to demonstrate that having 3 versions active at the same time would be a safe thing for the industry. And we also had the benefit of previous testimony when, an NCVHS itself produced a document saying, hey, what do you think, industry, what do you think about going forward, supporting multiple versions simultaneously? There was a ton of negative feedback on that. So we found ourselves this past time around with the X12 proposal that set up a condition that had undetermined risk. And I think that's where we are now for the digestible bites. We know we want to get to a more predictable system. We know what we need. We want to be able to budget it. We want to be able to plan it rationally rather than the system we have now, where even if a recommendation is made, there is really it's a black box process from the time it comes to NCVHS to the time it goes into effect by CMS regulation, by HHS regulation. So that's what we're seeking to address in the terms of digestible bites. How is it manageable? The other comment on that, for those of you that aren't aware, is part of the reason for that is because historically, the updates to the HIPAA adopted transactions have come about once a decade. And the consensus testimony from the industry on that is very, very insufficient, and that is not a good state to be in. And yet that's where we find ourselves, but we have yet to identify a course forward that meets all the constraints of the various legislations, the HHS regulations, the Federal Administrative Procedures Act, and what it takes for industry, both in terms of standards development, review and approval process, and then implementation. So that's kind of one of the holy grails that NCVHS is working on. And I think there's some good ideas out there. Trying different things or exploring different ideas is great. And I hope that WEDI will and all its members will stay engaged with NCVHS during the process of the standard subcommittee.
I just want to know, we ran over because of Donna's question, but I hope it was answered. And the other thing is, you know, when you're talking about these NCVHS recommendations, you know, I see it as a positive thing. And I think we all need to have that dialogue, whether you agree or disagree. What is the best way to move forward for national implementation for all our stakeholders? So again, I hope you continue to take that challenge and continue to find ways to work forward so that we can, you know, get to the end state that we all want to get to. So thank you. You guys enjoy lunch, and I really appreciate your time today. Again, thank you, Rich. Again, thank you again for your legacy.
Thank you, and thank Charles for those lovely comments earlier on. I'll miss you guys.
Thank you so much, Tammy and Rich. And we will now break for lunch and resume at 1:30.